proposal on this would be current or significant history of pulmonary disease, active tuberculosis, or severe or symptomatic asthma while on medication.
It has to be or severe asthma if symptomatic on medication.
Or severe asthma if symptomatic on medication.
That,
I like that. Or severe asthma. If symptomatic on medication. Further discussion on 5?
Did you say 7?
I said 5. All right, 6. Current or history of pulmonary embolus or deep vein thrombosis. Should that be venous, by the way, or is that proper?
that's
Either way.
Okay. You got a thumbs up on that?
Well, why doesn't it say significant history, just like all the others?
They're all significant.
Is there an insignificant pulmonary embolus?
All right. 7.
Moving on.
Current history of epilepsy.
Can we go back for just 1 second? I do have a question about the woman who's on oral contraceptives and has an embolism and now is no longer on oral contraceptives anymore.
Pregnancy also puts her at risk.
Okay.
All right.
7, current or history of epilepsy. And I have a suggestion from conversations that should exclude childhood febrile seizures.
But we're talking about epilepsy.
That's not epilepsy.
It was just to deal with the patient-reported history issues and like what are they really reporting? So that's why we suggested that.
Might just add the word excluding resolved childhood febrile seizures. I think patients have most people don't understand necessarily seizures may not equal epilepsy. So.
Right, but the practitioners do. The midwives will. I mean, you could also have a seizure from a reaction from a medication. You can't. I don't think you can also list every cause of seizure that's not epilepsy.
And if you want to leave it out,
What's wrong with listing that one? There's nothing wrong with it. It's not changing any. It's not
True.
increasing any limitations. It's actually giving you more liberty, giving us, giving the midwives more liberty.
That's true.
Except someone may look at it and go, why is that even in there? Because it's not epilepsy.
But I think Sarah's point was that a lot of people confuse it.
Right.
And think that it's epilepsy when it's not. And so
Yeah, but anybody evaluating the cases aren't going to confuse it.
I thought I just wanted it to help for you, so we don't have to have it in there if that's.
I mean, if no one in the midwifery community wants it, then that's fine. I was just trying to be helpful.
I mean, not to discount, if you're raising it, then perhaps it's been an issue where people are wondering, oh, does that count? Does that knock this person out? Do I have to send this person for a consult?
Well, I think it depends on who the audience for this document is. It's not the lay community, it's midwives and other professionals who would understand the difference between epilepsy and...
It's going, but there are a lot of people that are clinicians and, that are going to be looking at this law. So I think you've got to assume that the patients are looking at that too. And I think I just had this with my 26-year-old, that he got it officially put on his document that he had epilepsy. It's like, no, he just had so he talked to that to a physician, and it got put that he had febrile seizures, and it got put in his record. So
well, then maybe it should be put in for consumer, because right. This is targeting consumers, right. And consumers don't know the difference between an isolated incident that's not necessarily epilepsy, then maybe it should be put in.
Could it hurt?
Let's go for it.
Okay.
So would that be excluding resolved childhood febrile seizures or excluding childhood febrile seizures? But it's childhood, they're not pregnant.
childhood anymore.
Yeah, they're not,
They're
yeah.
resolved.
It
We
doesn't
still
need
have
to
the
be
seizures
resolved.
in adulthood, it's not childhood federal seizures.
Exactly.
Sears has brought up resolve.
So you don't need to resolve.
No
You don't need to
resolve.
resolve.
They're not pregnant as a child. Hopefully.
Another suggestion is in brackets to say epilepsy excludes childhood febrile seizures. Right. That's part of my concern is that if you carve out this one thing,
Then you're defining what epilepsy is.
but then again, if you're saying this is the most common confused issue and it would be helpful to have it in,
I don't know if it's even worth taking this much time.
I'm pretty sure it's not.
okay, I'll just stay awake at night for.
Could you say current history of true epilepsy?
What's
Well,
the
my
definition of true
my thing would be like, when
epilepsy?
you have a client form and they're putting on there, they're the ones who are saying
look
what their
it up.
conditions are, and they're the ones who's gonna say, epilepsy, just thinking because
Right.
they had seizures, they
Right.
have epilepsy.
Yeah, but
Because I
then
think it needs to be hashed out some way, because when I'm looking at that form as a midwifery student, and they're saying that, is there gonna be something that says like, I need to definitely ask them, do they know the difference between that? And most clients don't, they'll put it on there.
Yeah, but that's part of taking the history. It's just part of taking, it's part of our job, to take the history and figure out what is she talking about when she says she has a history of epilepsy. Tell me about your seizures. Oh, well, I had, a couple of times when I had a fever when I was a kid. Okay, well, we figured it out. If she took medication for seizures up to 3 years ago, then it doesn't have anything to do with childhood febrile seizures, does it? I think it's superfluous language. To have that in. I think epilepsy is epilepsy.
To you as a midwife, not necessarily as a client who's telling you what their history is. They don't know that.
But they're not gonna, you have to be the detective.
Well, I understand that. I'm just saying if we're this language, like, Jen said, it depends on who is reading it.
Well, a layperson's not gonna understand any of this stuff.
They will understand some and some they won't.
What's a pulmonary embolus? What's a, right.
I agree with
What's a
Sarah.
lumpectomy?
All right, I think that it's, the language is not necessary. Someone is going to point that out in comments during the 45-day comment period, and it's going to come out anyway, so I say we leave it. Number 8, the collagen vascular diseases.
I have a question on this one. I think that it should specify active collagen vascular disease. I'm not sure what benefit a woman's going to have going to an obstetrician saying, I have lupus, but I haven't had any issues with it for the last 2 years. I'm in remission. So I question just collagen vascular disease versus those that are not in remission.
Symptomatic.
But lupus doesn't go away. You always have it, and it may flare during pregnancy. It may not.
But if
it
it's
may
in
flare.
remission, it's likely to stay in remission in pregnancy, and if it flares, then it's the point that's in the current pregnancy. Then they need to be referred. I think the history of it shouldn't require. The obstetrician's going to say, well, you have lupus, and it's like it's in remission. It's likely to stay in remission. If it flares, then we may have to do something about it.
Do you take medication the whole time?
Yeah,
You've been
a
diagnosed
lot of
with
these conditions do require medications, and there are certain things that we would evaluate in pregnancy if she had a history of lupus, or if she had a history of Marfan's disease, or whatever it might be, that might affect her pregnancy. Yeah.
It's not prohibited. It's all this that there would be consultation.
So we have a suggestion to add active or symptomatic collagen vascular diseases.
I think we probably prefer to leave it the way it is.
I don't have a problem referring a woman who has lupus for a medical evaluation before I decide to do a home birth. I don't know about the rest of you. I'm good with that.
Okay. I think we know where we stand, so appreciate the comments. Number 9, significant hematological disorder or coagulopathies. That's it? Okay.
Should we define what significant hematologic disorder is? So does somebody with alpha thalassemia minor, that's not significant? So is ACOG in agreement that that's not significant?
Again, you can go significant for every one of these, and it's the eye of the beholder.
Right.
And we're not going to be able to find significant for each one of these. Again, we could spend all day talking about what is a significant or not significant hematologic disorder. But there's no way we're going to parse out each individual disease.
10, current or significant history of cancer. 11, isoimmunization. I love the inside jokes, like, duh. Yeah. Okay, haha. 12, history of 3 consecutive spontaneous abortions. I have a suggestion that it be history of 3 consecutive unexplained spontaneous abortions.
Why is it there at all?
Yeah.
What is a woman gain by going to physician for this?
If she's already pregnant, no.
If she's already pregnant and she doesn't have a history of a coagulopathy, which we can figure out before we send her.
Personally, I think when somebody's already pregnant, this particular history is unlikely to affect the current pregnancy.
Right.
So, I mean, there may be an underlying issue of thrombophilia, and I don't know if actually thrombophilia is even on this list, because I guess that's a coagulopathy. So, I think we've already covered that. So, if you wanted to recap, that's probably fine.
Okay. Yeah. Okay, we have, yes.
There's been a discussion of going back to the cancer just because of cervical or skin cancer. Is it any kind of cancer?
It's significant history. Determined by the midwife as to whether it's significant.
Kind of thorough remission.
Yeah, I mean, I think if you have a history of a basal cell carcinoma that's been removed,
It's not significant anymore, is it?
right.
You get a lumpectomy for breast cancer or something like that. You get a lumpectomy for breast, it's up to the practitioner to decide what's.
Right, there is some built-in professional flexibility in here to figure this out. Okay, number 13, history of cervical cerclage. And on the chart, I had that's deleted by agreement.
No, that we did not agree with that.
So that's marked as deleted from the prior interested parties meeting, where ACOG had different representation. So when we talked about it on the phone, we discussed it some more and agreed potentially to history of cervical cerclage unless the client is already 37 weeks, in which case it's irrelevant.
Okay. Dr. Adams?
It was deleted when it said history of cervical incompetence. And then we changed it to history of cervical cerclage, but then it said history of cervical incompetence.
Yeah,
I think on this one, it's always said cerclage.
There were both, and they were fine.
Right.
I think we deleted it on the, arising during pregnancy, that was something there that said evidence of cervical incompetence or something. We took that off there because we had history of cerclage here.
Can I just ask, because it's been years since I took care of somebody who had 4 cerclages during hard care. In those particular women, they took the cerclage out at 35 weeks, and now people keep them in until 37 weeks. I mean, they had them put in at 18 to 20 weeks, and then the physician removed them at 35 weeks. Is that still what people do, or do they
Usually they're removed at 36 to 37.
They go into
36
term labor.
36 to 37 weeks is when we typically remove cerclages.
Is this saying that this is a history of cerclage in a previous pregnancy?
Right.
So my question is if somebody comes into your practice at 34 weeks with that history, you actually need to send them to a physician for a consultation? Where did the 37 weeks come from? As far as I know, that's when you can suddenly start to take care of them.
Right.
But it doesn't make any sense to me if their cervix is, now they're 34 weeks pregnant, they haven't shown any signs of a confident cervix in this pregnancy, but they have a cervical cerclage in place in their last pregnancy. Why do they need to get a consult at that
Yeah, they
point?
don't. But at which point do they not? What gestational age do they not? Does a consult no longer serve them?
Well, after you wouldn't put it in anymore, which is early on, because most people aren't doing cerclages in the second trimester too often anymore, because they feel that, at least the study, you probably more often studies than I am, but a lot of the studies show that pelvic rest or putting a cerclage in there should basically get the same outcome. So, they often will put them in at 12 weeks after they document viability, but you don't see people putting them in at 22 weeks anymore, unless they walk in with bulging membranes or something like that.
And we still do
That's
put them in
different.
at 22 weeks.
Prophylactically.
Not prophylactic cerclages, but
No, but I'm saying prophylactically.
But the woman would be having symptoms if you were going to put one in at 22 weeks.
not necessarily symptoms, but she might show cervical length on ultrasound or on examination. I mean, it's hard to say exactly at what gestational age we should say, okay, this is no longer a significant history, and it
You're not going to put one in at 32 weeks.
No, we're not going to put one in usually after 24 weeks, but then some people still do monitor cervical lengths on people with a history of a cervical cerclage who decline a cerclage during this current pregnancy.
Yeah, the data isn't clear on that, though
No, it's
they
not
might
clear.
certainly refer for ultrasound if you wanted to monitor cervical length too. The doctor would see her one time and say, oh, I monitor for cervical length, and the patient can make a decision. But I'm just saying, if somebody comes in at 28 weeks, 29 weeks, 34 weeks into your practice and they've had a cerclage in the previous pregnancy, seeing a doctor at that point isn't any benefit that I can see as a practicing
It would be
physician.
difficult to argue that there's any benefit to having a consultation if she presents at like anything greater than 30 or 32 weeks, because even then we're not going to do much different. Even monitoring cervical lengths is of limited utility at that gestational age.
So would you be open to adjusting that 37 to, say, 30? So for client selection, we can't take this mom without a consult unless she's already 30 weeks at entry to our care.
You can still follow the patient, it's just a question whether they have a consult physician. And I mean, if we're going for patient safety, then I would err on the side of being safe, and I'd say 32 weeks instead of 30. But I mean, we're just making up medicine here. And
level C.
well, I mean, so that as soon as you're trying, no, this is level X. This is based on the opinions of people sitting around this table. And no offense, I'm not an expert in cerclage, and I mean, there are people far more expert than people in this room. And I think we're just making up medicine here.
Well, I would disagree to that. We're not just making it up, but both of us have had experience and data on this, and that we both even agree that at a certain point you're not going to put cerclage in somebody, and you're not even probably going to monitor their cervix. Now 32 weeks is a reasonable number. At least it's more reasonable than 37 weeks. So, I mean, it's something. You know, if you take, you're probably not going to burst cerclage at 26 weeks unless they were symptomatic, or unless you accidentally found that they were, you know, that if they had a very, very short cervix, you might, but a lot of other doctors would not. So you might follow them differently, but that's something that, again, midwives can collaborate as they see fit. I was just saying that the 37-week number was completely not scientific. There is some science to the 32-week number, the 30-week number at least. That's all. Yeah.
37 week isn't pretending to be science, it's only pretending to refer to statute.
Right. So, I'm going to suggest we put the language in here, unless already at 32 weeks gestation, and
I would put if less than 32 weeks gestation at entry to care.
of what?
If less than 32, history of cervical cerclage is going to require a referral if she's less than 32 weeks at entry to care.
Yeah, that's better word. That's better wording.
Yeah, that's precise.
Carrie, can you put your mic a little closer?
Yes.
By the way, that's going to be the unusual scenario anyway. Most of you guys don't pick up patients at 32 weeks. So.
We do sometimes when they're unhappy with what I've done.
And then they've already had
Then they've already had the consult for the 6 months.
Let me read this back to you, Carrie. History of cervical cerclage of less than 32 weeks of gestation at entry of
To
care.
care.
To care. Okay. All right. 14. Previous unexplained neonatal mortality or stillbirth.
I have a comment about that. I have had, in the course of my life as a midwife, I've had 3 mothers who had a previous stillbirth. At the time of the stillbirth, either stillbirth or neonatal death, and at the time, every test that could possibly be done was done, and they had no clue. So there wasn't like they were going to be able, it's going to be any different the next time she got pregnant. There wasn't anything to look for, there wasn't any explanation. I just don't understand how this is helpful.
I agree. How does this improve a woman's care?
So a lot of perinatologists may start antepartum testing and non-stress testing later in the 3rd trimester or close to the time where she had a previous stillbirth. So that would affect her current pregnancy.
We can order that. That's what we do too. We can order that. That's no different than the care we give.
I'm not sure that that's evidence-based, but the standard was always that at a stillbirth at 38 weeks, you'd start testing at 36 and a half. You just did that, but I don't know that there's a lot of data for that.
Midwives are well equipped to do that. I mean, I don't see how referring to a physician to have them say do this when we're already going to do this, whatever this is, helps anybody.
I mean, I think the idea is to have a backup to make sure that some important test doesn't get overlooked. And that's why I have a patient with lupus. I'm always going to send the patient to an FM or an endocrinologist or somebody who knows more about that disease. And I just think it's the goal here, I think, is to have an extra layer of safety to make sure that important tests aren't being overlooked.
Can I just say something about